All right, welcome back to the Trauma Therapist Podcast. My name is Guy McPherson. My mission is to raise the awareness of trauma and to support and inspire new trauma therapists just starting out on the trauma-informed journey. I do that with my membership community, Trauma Therapist 2.0, my online courses and workshops, and the Trauma Therapist newsletter. If you're a therapist of any kind and you work with individuals who've been impacted by trauma, I invite you to head on over to my website at thetraumatherapistproject.com. That's thetraumatherapistproject.com. All right, let's get started. You ready?
I am.
All right, here we go. All right, 5, 4, 3, 2, and 1. All right, everyone, I am thrilled to have back Dr. Deborah Korn on the podcast here. Debbie, welcome.
Thank you so much.
Debbie maintains a private practice in Cambridge, Massachusetts. She's an adjunct training faculty member at Bessel Trauma Research Foundation and is a senior faculty member at the EMDR Institute. Dr. Korn has co-authored or authored numerous articles and chapters focused on EMDR therapy, including comprehensive reviews of EMDR applications with complex PTSD. She presents and consults internationally on the treatment of adult survivors of childhood abuse and neglect. Her new book about EMDR therapy, Every Memory Deserves Respect, co-authored with Michael Baldwin and written for the layperson, is now available in bookstores online. And I should just say, I don't know if I said this, but you joined me back on episode 547. Thrilled to have you back here. Like I said before we were recording here, your message and what you do and who you are, you exemplify what I'm hoping my podcast is about. So I'm excited to have you back.
Thank you.
You're welcome. So when I invited you back, we talked about, well, what were we going to talk about? And my goal in bringing you back was maybe to get a little more specific, which we don't really do on the first time, but I invited you to share maybe about a case, and the goal here is to really dial in and see how you do what you do.
Yeah.
Go.
So first, let me just say something about EMDR therapy for those that are less familiar. So EMDR therapy is a memory-focused psychotherapy. It was developed by Francine Shapiro in the late 1980s. And it's based on the idea that psychological and some physical problems are related to the failure to adequately process traumatic memories. And, what we believe happens is that these memories, these experiences get locked in the nervous system with the feelings, the sensations, the cognitions, the impulses, the thoughts associated with that original experience. And then along comes a trigger, experiences in present day that reactivate that constellation of experience, leading to symptoms. So because of this malfunction or the freezing of these traumatic memories, the isolation of these traumatic memories, the brain's information processing system is unable to digest the experience. It's unable to resolve the experience. And so when a person gets triggered, the past becomes the present. So in EMDR therapy, we work to identify the memories, both recent memories, recent triggers, and memories connected farther back, connected to childhood, that need to get processed and metabolized or digested. And throughout the work, we're really diligent about making sure that the client maintains what we call dual attention at all times, right? One foot in the present, connected to the therapist, connected to the adult perspectives as they lean in, as they dip in to and access these earlier memories. So I just wanted to begin with that quick overview.
Okay.
So
can you say a little bit more about why that dual awareness is important?
Well, it's critical because we don't want the client to get flooded. We don't want them blended with a child state. We don't want them flooded by the earlier experience. We always want them oriented, grounded in the present, and able to observe, bear witness to what they experience, able to stay regulated in their optimal arousal zone, bringing in new perspectives, adult perspectives, present day perspectives to help metabolize the earlier experiences. If they were not able to stay grounded and in that observing, mindful stance, there's the potential for the work to be re-traumatizing. And we want to avoid that at all costs. We want the work to feel safe. And we want the client to stay regulated throughout the work, because that's an imperative for the work to be effective.
Great. Thank you.
Right. So I thought I would tell you about Mark. That's not his actual name, but I'm going to call him Mark for today. Mark is a young doctor, white, heterosexual, married man in his late 30s. He was working on a COVID unit during the first major COVID surge here in Boston in 2020. And he had a history of mild intermittent depression over the years since adolescence, and a few brief failed, he would call them failed attempts at psychotherapy. He claimed that psychotherapy had made him worse in the past, not what we like to hear. And for months at the start of the pandemic, he was working round the clock with inadequate supplies, limited support from hospital administration. He lost many, many patients to COVID. Now, he was not new to intense inpatient work. He, of course, had lost patients previous to this surge, but it was the combination of these circumstances, right? The overwhelm, the stress, the powerlessness that was quite unique to this period of time. So he started to get more and more depressed. He developed PTSD symptoms related to the unexpected deaths of a few patients in the hospital. He started having nightmares, intrusive images. He became quite hypervigilant, extreme irritability. He simultaneously described himself as feeling dead or numb inside. He also found himself throwing things, not at any people, but throwing things all the time in fits of rage. And this behavior was quite uncharacteristic for him, and it really worried and frightened his wife. He was unable to sleep. He was unable to concentrate. He was unable to make decisions. He started drinking to try to get to sleep at night and to manage his intrusive PTSD symptoms. He described passive suicidal ideation, ruminations about, wishing everything would go away, maybe that it would be better if he was dead. And he eventually took a medical leave from work and sought treatment with me. And so we came together, and I began by taking a basic history. Did you want to interrupt?
No.
Okay. So Mark grew up in a family where his father regularly beat his mother, severe domestic violence situation. And this was the case since he was very, very young. And on 2 occasions, his mother had to be hospitalized because of injuries. His father was an alcoholic who eventually left the family when he was about 8 years old. And his father later died when he was in college. When Mark was in college, his father died of alcohol-related complications. And even though she was quite depressed, he felt like his mother loved him. He felt loved by his mother, and later by a stepfather who was incredibly supportive, particularly with regard to his dream of becoming a doctor. So when Mark came into treatment, in terms of my case conceptualization in the first couple of sessions, Mark had no idea why he was suddenly having such a hard time coping with life in the hospital, with life in general. He saw no connection between recent events and anything that had happened earlier in his life. And in exploring his history and his current struggles, it became very clear that the recent events in the hospital, right, the unexpected deaths of patients, the sense that he didn't do enough to save them, the sense of powerlessness, the sense of feeling invisible in dealing with authority figures and administration, became clear that those events had triggered unprocessed memories from childhood related to his father's abuse of his mother and the situation in his household. He had actually been working quite hard throughout his life to keep those memories at bay through his workaholism, through avoidance of intimacy and heartfelt connection, through emotional numbing. He had devoted his life to rescuing people, and he never slowed down enough to feel or process or reflect. For those listeners who are familiar with attachment styles, he had a very avoidant, dismissive attachment style, right? Kind of cut off, constricted, self-sufficient. And we decided to begin by targeting the recent COVID-related deaths, since his most debilitating PTSD symptoms were related to present day traumas, to the deaths of the patients in the hospitals. That's what he was having nightmares about. That's what he was having flashbacks about. We agreed that we would then explore any connection to earlier life experiences, childhood experiences, and we'd move on to do that work if it seemed warranted. Mm-hmm. So the very first thing we did in treatment was, the very first thing I did was I talked with him about safety and sobriety, right? I said, before anything else, the only way we're going to be successful at this work is if I know that you are committed to living, to life, and that you are able to refrain from drinking as a solution, as a way to numb out, push stuff away. And he made a sincere, I sent him home to think about it. I said, don't give me a quick answer, go home, sleep on it, think about it, come back and let me know. And if you tell me you're committed, then we go forward. And he came back and said, no, I want to heal. I want my life back. Let's go. I educated him about EMDR. I told him that I felt very hopeful about his capacity to recover and to heal completely using EMDR therapy.
Let me just interject you, because you're saying a lot of really interesting stuff, and I want to see if we can flesh this out a little bit for our listeners here. Excuse me. So when he came in and he shared his background, as you were sharing his background, I mean, I'm thinking to myself, wow, there's so much going on here. When he initially shared this with you, what were you thinking?
When he shared
when you were taking his history, what were you thinking of possibilities in terms of
his memory network, what his brain was holding was lighting up for me, and the connections were lighting up for me. In EMDR, we're always thinking schematically, thematically. So I was thinking about over responsibility. I was thinking about how he had a history of holding himself responsible for not doing enough, not saving his mother, not protecting his mother as a little boy, right? I thought about the lack of safety in his world, the lack of getting anybody to notice and pay attention and take the situation seriously. I thought about the powerlessness of his childhood, and how, our doctors and nurses and frontline people during this pandemic have felt so powerless to be as effective as they want to be. So I knew that we needed to go after the more recent experiences first, because clearly this PTSD that he was experiencing first and foremost was related to what had happened recently. And in EMDR, we have specific protocols. We call them early intervention protocols. I use a protocol called RTEP, Recent Traumatic Episode Protocol, to address recent experiences. But I also knew that if he was going to get relief from his longer term depression and his longer term struggles in terms of kind of self-concept, right? Never quite good enough, always feeling a bit like an imposter, deep down feeling a bit like a failure. I knew we were going to need to get to that earlier stuff, but I knew that that would be a choice for him, whether he wanted to go on and do that deeper work. So we began with the recent experiences. We kind of lifted the most intense symptomatology, and then he was pretty darn convinced that of EMDR's effectiveness, and so he wanted to continue on.
Okay.
He was able to return to work after 6 weeks of treatment.
Okay.
He returned to work.
He was on medical leave when he came to see you?
He was on medical leave.
Okay.
He'd been on medical leave for a little bit. After 6 weeks of treatment, we were meeting twice a week. He was able to return to work. We did a lot of preparation to help him return to work. But the therapy continued. Overall, it was a 6-month therapy. We reduced to once a week after the initial intensity. And he was able to complete the rest of his work in about 6-7 months.
How did you present to him the idea that you were going to work on these recent triggers or the recent traumas, in a sense? What did you say to him? What did you do, etc.?
I explained to him that we were going to take a look at the recent experiences that seemed to be at the heart of his current symptoms. And that it was not difficult to determine where to begin with him, because he was having these clear-cut intrusive symptoms, right? Which is just one part of PTSD, but it's kind of the low-hanging fruit in PTSD treatment. When intrusive symptoms, if there are intrusive symptoms, we're going to go right there. So I explained to him that I was going to ask him to think about the worst moments, the moments that were haunting him. And I was going to ask him to activate the memory through a series of questions that I was going to ask him. So what picture represents the worst part? What's the negative belief that comes up about yourself, right? I'm powerless, I'm a failure, right? I should have done more. As you think about this, what would you rather believe about yourself? If we could do a good piece of work here today in order to carry on, what would you rather believe, right? I have choices, I'm powerful, I do what I can, I'm good enough. We'd activate the feelings connected to it, the sensations connected to it. And then we would begin by introducing bilateral stimulation, which is, I was working with him virtually. So he was watching a ball on a screen. I use something called EMDR remote, which allows the client to follow a ball and listen to tones that go back and forth. And that his only instruction was to stay connected to me and to allow whatever happens to happen, right? Whatever emerges, we would do a set of bilateral stimulation where he's tracking, we'd pause, and I'd ask him to please just report on whatever he was noticing, right? And his job was to maintain that dual attention, right? Stay connected in an observing stance. The goal is not to relive. The goal is to observe at a distance, to maintain, that ego distance from the material, and to report on what was coming up. And those were the instructions he got going into the work. And I told him that I would be at his side. I'd be with him every step of the way, that I was not going to let him drown. And different than when he was a child and he was faced with overwhelming feelings, he would not be alone this time, that I would be right there, and that we would work in a way and we'd pace the work so he would not get overwhelmed.
Now, this sounds really incredible to me. And I want to say something that might sound stereotypical, but first of all, here we have a physician who, in our reality, in the current state, we think of as highly educated. They are highly educated.
Yes.
And we have in our culture, we have certain ideals about how they are, right?
Yes.
And you're saying here that he felt powerless and not good enough, and that directly contradicts how we generally think of physicians. Right. I'm also struck by the fact that, initially he said he had experiences which were failures. And a lot of times, again, this is stereotypical. A lot of times we hear of Western medical doctors who maybe don't have the highest regard for therapy, for talk therapy. Mm. So how did all that flesh out in your experience? Obviously he came to you because.
Yes. He came to me because another colleague of his, one colleague, had confided in him that he was also having significant PTSD-like symptoms, and that colleague of his had gone for EMDR therapy. So he went looking for an EMDR therapist. He had not had good experiences with traditional talk therapy previously. This is a guy who had tucked stuff far, far away, right? Who was pretty cut off from his emotions, his history had kind of been disavowed, not important to his present life. And he had managed that way for a long time. It had worked for him. right? His workaholism and his numbness and his distance from people kept it all at bay. But he's smart. He's a smart guy. And he knew, or some part of him knew, even though he wasn't connecting all the dots at the start of treatment, he knew at some level that this material that he had worked so hard to tuck away was starting to rear its head. And he said to me, I've worked in hospitals for many years now. I've had patients die. I don't know, yes, we're in a pandemic, but this is what I train for. I don't understand why it's catching up to me. It's hitting me this way. He had not connected the dots. But as soon as we started exploring the history and I started asking him to float back, like notice the feeling in the pit of his stomach, that knot in his stomach, the fear, the sense of powerlessness, the sense of paralysis, like wanting to scream, but not being able to move, which is what he used to experience as a child when his mother was being beaten. And I asked him to notice that feeling in the present that was part of his current symptoms and to float it back. And it took him directly back to childhood experiences. He started to get it.
And in a way that his other experiences with death as a physician, things weren't as triggering for him as they were now.
Those memories that had been locked away, frozen in his nervous system, had not gotten activated for whatever reason. I think, again, it was this combination of triggers, right? We're in this worldwide pandemic, supplies are limited, administration is not getting it, not stepping in to help, he's not getting enough sleep, lots of vulnerability, poor self-care, all of that was just, I think, bearing down on him.
Debbie, what do you think? What other ways, maybe less successful ways, could you have gone as a therapist here? You said you went for the low-hanging fruit. You could have opted not to do that, right? You could have made other choices. What are some of those other choices that might not have been as successful, do you think?
The main crossroad that I faced was, I could have gone in other directions in terms of using other treatment modalities, but in my mind, he was a great candidate for EMDR. He had good support in his life. He had a willingness and a readiness. He was motivated to do the work, even though he was a bit affect phobic, with reassurance, with support, with initial work that I did with him around developing some strategies for tolerating affect and staying regulated. I had a lot of confidence that this direction was a good direction for him, but I could have used other models like internal family systems or sensory motor psychotherapy, any of a number of other models. But for me, the real crossroad was around deciding whether to target the recent experiences first or to float back to what I knew was underneath, and to begin with the earliest or the worst. And in EMDR, we often look for the underpinnings. We go after the first or the worst experiences of powerlessness or experiences of terror, whatever it is the client is coming in with symptomatically. We look for where it began or where its origins might be. But in this case, the current events were hot enough. They were traumas in their own right. They weren't just triggers for earlier stuff. They were traumatic, I would say big T traumas. And so I opted to go in that direction first. And I think that was the right decision because we cleared out his PTSD symptoms pretty quickly.
Wow.
And then his functioning started to rise. And then we were able to go toward the longer term developmental trauma or childhood trauma, which helped him, I think, heal in much, broader, profound ways.
How long?
Kind of complex PTSD.
Okay. How many sessions, how long did it take between when you started the EMDR to when you were able to get a good handle and kind of mitigate his symptomatology?
I would say about a month. We were doing 2 times a week
Right.
sessions,
Okay.
extended sessions. So for me, an extended session is 80 minutes, which gives you time to check in about how the person's doing, to do this deeper, emotionally focused work, experiential work, and then to make sure we close it up, we put it away, we put it in a container, and they're able to carry on. So I would say, we moved into trauma-focused processing after some preparation work, some skills work, relational work, in about 3 or 4, maybe the 4th session.
Okay.
And then, yeah, I would say in a couple of weeks, he was feeling better. He got relief after several EMDR sessions. He got relief after every session, but he started talking about, I think I want to get back to work. And then, like I said, he went back to work at six weeks. But that was after we did kind of some stabilization work. We did trauma-focused work around the recent experiences. We didn't touch the early stuff other than naming it, that it was there. And then we helped him do what we call in EMDR future templates, which are inviting him to with the new beliefs about self, the new feelings, right? I have something to offer. I have choices here. I can take care of myself and other people. I'm not an imposter. I'm a good guy who has a lot to offer. We were able to help him imagine, play a movie of future coping, dealing with different situations. So returning to the hospital, seeing his colleagues, dealing with administration, dealing with a future death of a patient, anticipating how he was going to respond to that, and preparing for that. Preparing for future disappointments with administration. So we kind of tackled all the future stuff as well. And then he was really ready to head back.
How does it work? I mean, to come into a session initially and have these beliefs about ourselves, oneself, that are maybe negative or limiting. How did it get to the point where he was able to cultivate a new belief system?
It had to do with the reprocessing of the memories.
Yeah, that's amazing.
As he processed the memories, he grieved, right? He cried for the losses. He got angry. He was able to put into words the anger that he felt toward the administration that he had not been able to directly express. Like in imagination, he was able to speak those words, right? He was able to review the events around the death of these patients and was really able to say, you know what? I did everything I possibly could have done with what I had available to me, right? It wasn't my fault, right? I am a good doctor. So outside of the activation, the arousal, the dysregulation of the traumatic circumstances, he was able to see it differently and integrate that perspective. He was able, he was able to say, yeah, I was powerless to do more in that moment, but that doesn't mean going forward, learning what I've learned, all of us learning what we've learned, that I will be powerless going forward. And he was able to realize that so much of what he was experiencing in the moment related to the hospital was a merging, right? Was an intersection of the realities of present day COVID treatment and his history, growing up in a family with an alcoholic dad, with an abusive dad, with a depressed, passive mom, where he was a little boy, right, and where he was powerless, where he couldn't do much of anything to stop his father, right? Where he had profound shame and guilt and paralysis about being impotent, ineffective, right? And an interesting thing, a very interesting that came up in the course of the processing was, remember I said that in his depression, in his irritability, he was throwing things, and that was frightening his wife, frightening him. When we eventually got to the work around his childhood, when we floated back from the recent experiences and the recent triggers back to these early experiences and targeted various experiences where he was witnessing the abuse of his mother, he recalled several incidents where he would hide as his mother was being beaten, literally unable to move, frozen in terror. But the one thing that he would do was he would grab things, and from hiding behind a chair, he would throw them at his father, trying to get his father to stop. And he'd scream, "Stop." Oh. And once we processed that, the impulse to throw things dissipated, and the behavior of throwing things, that intense irritability just ceased in his present day life. Oh my gosh. And he felt such compassion for himself as a little boy. And he was able to, in imagination, in the processing, set by set with the EMDR, he was able to imagine going to that little boy in his mind saying, "Hey, you were so brave. You did what you could do," right? He was big and strong and scary. And, if you had tried to do anything else, you may not have made it. You may have wound up in the hospital like your mother. But you look at what you tried to do, right? Tears, compassion, right? And kind of returning to more of an open-heartedness with himself. The self-hatred, the shame started to dissipate.
Where are you now with treatment with this client? Are you still seeing?
All done.
All done. Wow.
All done. And I only hear from him from time to time when he calls and asks me if I can see one of his colleagues, which he has referred numerous people. I haven't been able to see all of the people he's referred, but our folks on the front lines are in trouble.
Yeah.
They're really suffering. And like you said, we imagine our doctors in control and tough and brave, and they are. Right. They're tough and they're brave,
but they're also human.
They're human. And if they have trauma histories, and many of them do, many of the docs that I've worked with talk about their desire to go into medicine, had a lot to do with wanting to protect people, rescue people, help people, to make a difference, to offer kindness and healing to people when they didn't have that when they were growing up. So many of our docs have some kind of trauma in their history.
What was maybe one or two things that was particularly challenging for you in this case?
It was very challenging work for me because it was early in the pandemic and my nervous system was a bit dysregulated. We were all living in fear in the early days. We all didn't know who was going to get sick, when they were going to get sick. There were no vaccines. So, the intensity of his emotion and the stories that he was sharing about death were activating some of my own emotional stuff about being in this pandemic and worry for myself and my family. And so I really had to prepare for each session. I had to make sure I was very grounded. I was very regulated. I had to leave time after my sessions with him to, make sure I was putting any of the images that were coming up in the work with him to the side so I could go on with the rest of my day. I think I was a little closer to emotion than I might normally be doing work with folks. So I don't know that I would say it was a challenge or that it was a problem, but it was, there was something powerful in this work with Mark They brought me close to tears repeatedly in the work. And, I never know how that's going to land with a client, like if there's tearfulness in my eyes. And what was in, and I always meta process with clients. I always say, I'm feeling so moved by this work, or wow, I have such deep compassion for the challenges of this work that you're doing. You can see it with the tears in my eyes. What's it like for you to see those tears in my eyes? I don't know what that might feel like to you. Tell me.
Mm-hmm.
And in Mark's case, he said, I actually feel incredibly comforted by your tears. I feel less alone. I feel like you're getting it. You're seeing me and hearing me. Most people don't see how hard it is for us at sometimes, in certain circumstances. And I feel less alone because I can see that you're with me. You're really getting it.
Wow. That's so intense. I mean, I can feel it. You could, this whole case is so emotion filled. I mean, it seems so very intense. As we kind of wind down here, Debbie, I mean, there's so many, I think, takeaways, but in the wake of this, what are some of the things you did take away from this experience with Mark?
Well, I think, every time I work with somebody who is in distress about actual trauma in the present, while simultaneously dealing with what's been activated from the past, there's always a little part of me that's worried, like, what if I make it worse? What if we can't, I've said to him, you are a perfect candidate for this work. I can absolutely help you to heal. And for all intents and purposes, after 30 years of doing trauma-focused work and using EMDR, I feel pretty darn confident about it. But the stakes are so high, right? He's in such acute distress. He really needs to get back to work, wants to get back to work. So I think a case like this reminds me to trust what we have at our disposal to help people. It reminds me to be brave. It reminds me to trust my experience. And I think, it reminds me that even when a client cannot see those connections at the very beginning of treatment, it doesn't take much once we get clients more embodied, connected to their affect, connected to their bodies, and help them to start exploring back at that level, at that somatosensory level, that clients begin to understand in an experiential way that there are these connections and that they're feeling what they're feeling for a reason, right? That it makes complete sense, total sense.
Wow. Debbie, I want to thank you for sharing this. I mean, just it feels so intimate to get a window into this experience, into your experience and the way you work. Thank you so much for.
You're welcome. It's such a pleasure talking with you, really.
I appreciate it.
Yeah.
Take care. We'll be in touch. Okay.
Okay.
Bye-bye. Oh, wait a minute. Before we go, where can people contact you? What's the best way?
They can contact me via email, deborahkorn@gmail.com. And we also have a book website. The name of our book is Every Memory Deserves Respect. So the website is www.everymemorydeservesrespect.com. And they can also contact me through that website.
Okay. We'll have those linked up at the show notes page at thetraumatherapistpodcast.com. A pleasure. Thank you so much.
You're welcome.
All right.
Take good
Bye-bye.
care, guys. Bye-bye.
Thank you so much for listening and supporting this podcast. And if you'd like to join the hundreds of other therapists who are each month keeping up to date and informed and inspired about what's going on in the world of trauma, I'd love to invite you to head on over to the Trauma Therapist newsletter. That's the traumatherapistnewsletter.com.